Today's topic is nursing management for clients with Parkinson's disease. According to the CDC, Parkinson's disease is the 14th leading cause of death in the United States. As many as 1 million people live with Parkinson's disease, which is more than the combined number of people diagnosed with multiple sclerosis, muscular dystrophy, and ALS. Approximately 60,000 people are diagnosed with Parkinson's disease each year. The incidence of Parkinson's increases with age, but an estimated 4% of people with Parkinson's are diagnosed before the age of 50. Men are 1.5 times more likely to have Parkinson's than women. Michael J. Fox, and an advocate for Parkinson's disease research, was diagnosed with Parkinson's in his early 30s. He has brought more national focus on research needs for this particular disease. I have a link here for the Parkinson's statistics. Let's talk about the pathophysiology of Parkinson's disease. A thorough understanding of the physiologic aspects of the neurological system is essential for understanding the clinical manifestations, complications, and treatment of Parkinson's disease. Parkinson's is a progressive degenerative neurological disease characterized by bradykinesia, muscle rigidity, and non-intentional tremors. In Parkinson's disease, atrophy occurs in the substantia nigra that produces the neurotransmitter dopamine. In Parkinson's disease, as depicted in this slide, dopamine decreases acetylcholine, which is no longer inhibited. This imbalance in neurotransmitters is the clinical basis for the symptoms. Again, it's a dopamine problem, but acetylcholine is increased because of these dopamine receptors that aren't functioning. An imbalance between dopamine and acetylcholine. The large number of excitatory acetylcholine secreting neurons remains active, creating an imbalance between excitatory and inhibitory neuronal activity. The resulting excessive excitations of neurons prevents a person from controlling or initiating volunteer movements. Not only does Parkinson's interfere with movement as a result of dopamine loss in the brain, it also reduces sympathetic nervous system influence on the heart and blood vessels. This loss results in orthostatic hypotension. Patients will be more at risk for falling due to this. Parkinson's is separated into stages according to symptoms and degree of disability. Stage 1, as you can see here in this slide, is the early stage of symptom management, which is unilateral limb movement, minimal weakness, hand and arm trembling. All the way to stage 5, which incapacitates the client to dependence on others for activities of daily living. There are 4 hallmark symptoms of Parkinson's, which include tremors, rigidity, bradykinesia, and postural instability, which puts clients at a high risk for falls. Clients with Parkinson's tends to have a stooped posture, a forward tilt, blank or mask-like facial expression, and a short, shuffling gait. The following assessment pieces are focused on potential problems like impaired physical mobility, risk for falls, risk for self-care deficits, risk for impaired verbal communication, risk for imbalanced nutrition, risk for aspirations secondary to swallowing challenges, and risk for depression and anxiety, loneliness and social isolation. Clients may have gait imbalances and instability due to the effects of the disease on motor function. Dysarthria, or slurred speech, should be a hallmark sign for risk of aspiration. Autonomic dysfunction secondary to medication therapy can lead to orthostatic hypotension. Again, these patients, because of this, are at high risk for falls. Constipation and excessive sweating. The disease impacts clients and their family members. Psychosocial elements of care focusing on supporting clients emotionally is imperative. Now let's talk about diagnostics and lab values. Lab values that must be monitored are a complete blood count, otherwise known as a CBC, and a metabolic panel due to the risk for malnutrition and nutritional deficits. Diagnostics, such as an EEG, may indicate disease progression. Lastly, a swallow evaluation is necessary for types of diet appropriate for risk aspiration. Interventions. There is no cure at present for Parkinson's disease, thus the focus is on symptom management during the disease progression. Performing active and/or passive range of motion twice a day and ambulating at least 4 times a day has many benefits for clients. Because many of the medications can cause drowsiness, providing alternate rest periods and activity can manage fatigue. Supporting patients' self-care and daily activities, assistive devices may assist clients in being independent. As an example, adding Velcro to clothing and shoes can aid the encouragement of self-care needs. There are various assistive devices to support feeding and self-care. Also promoting a diet that facilitates peristalsis with foods high in bulk and fluids. Assess communication skills and support clients with particular therapies focused on speech, hearing, and writing skills. Medications are prescribed to treat the symptoms of Parkinson's disease with the purpose of increasing the client's functional abilities and minimize long-term effects. Monoamine oxidase inhibitors slow the main type B of monoamine oxidase in the brain, increasing dopamine concentrations in the brain. MAOIs should not be taken with foods or drinks and other medications with tyramine, which includes foods that are aged, like blue cheese, smoked, or cured. Also avoid red wine and beer to prevent severe headaches and life-threatening hypertension. Dopamine agonists mimic dopamine by stimulating dopamine receptors in the brain. Dopamine agonists are associated with orthostatic hypotension, hallucination, sleepiness, and drowsiness. Educating clients on avoiding driving while taking the medication, as well as slow moving from a lying to sitting and standing position, are imperative for those patients. Anticholinergics can help with tremors and ease dystonic association with wearing off or peak dose effects of this medication. Side effects are blurred vision, dry mouth, constipation, and urinary retention. Catecholamine O-methyltransferase, or COMT inhibitors, have no direct effect on Parkinson's symptoms. Instead, they are used to prolong the effect of levodopa by blocking its metabolism. Antidepressants may be warranted for psychological aspects of being diagnosed with Parkinson's disease. Propranolol, a beta blocker, can also be used for tremors. Surgical management for symptom control is a last resort when medications are not effective in symptom management. A thin electrode is implanted in the thalamus or subthalamus and then connected to a pacemaker that delivers electrical current to interfere with tremor cells. You can see here the picture about a brain stimulator. Another surgical intervention is stereotactic pallidotomy or thalamotomy. This procedure involves using a stereotactic head frame while a small burr hole is made into the cranium. An electrode is inserted into the target area. The target area receives a mild electrical stimulation and the client's reaction is assessed for reduction of tremor and rigidity. When the ideal location is found, a permanent lesion or scarring is made to destroy that tissue. So evaluation of the desired outcomes. Because there is no cure for Parkinson's disease, the desired outcomes is supporting the client and family with managing symptoms and self-care. Exercise programs like yoga may improve mobility and mood along with active and passive range of motion. Encourage self-management by having the client participate in as much self-care as possible. Provide a safe environment and monitor behaviors affected by medication administration, like drowsiness and unstable gait. Collaborate with the client and nutritionist to ensure the client's food intake is adequate and support secondary complications such as constipation and trouble swallowing. Supplemental feedings may be needed in the later stages of Parkinson's disease, secondary to malnutrition. Support communication needs by assessing whether the client may need speech therapy. Psychosocial support from the client and family members may be needed and assessed. Collaborate with social work, case management, and home health agencies to ensure the family and client have resources for the various stages of the disease progression. Lastly, education on administration of medication management is warranted. In particular, long-term medication therapy can lead to drug toxicity and drug intolerance. A drug holiday, which typically lasts up to 10 days, where the patient receives no medication, may be warranted. This is quite stressful for clients and family members during this process. This concludes the presentation on nursing management for clients with Parkinson's disease.